Good morning. So, welcome to 14th day of thorax. Now, in thorax, we are studying cardiac pharmacology. Three good reasons. Three reasons. See, the first reason, when I said that we'll be learning in an integrated approach. Now, see, we have talked about cardiology so much, right? We have learned ECG, we have talked about even the functions of the heart, we have seen the anatomy. So, now is the time, why not to touch the pharmac part? Because in second year, when the pharmacology would come, who knows, at that point, ideally you should have remembered, you should be remembering everything very crisply, but it matters. Sometimes some things, some points they are messed up. But over here, if we give a touch to pharmacology now, you'll find that it is much easy to understand the whole thing. Right? You'll realize this thing today within an hour. And by the end, we'll sum up everything in one page. So even if you don't look at the entire PDF, that one page would be sufficient for you to remind almost every point. Right? This is the first reason. Second reason, as our intention is, say you all appear for your USMLE step 1, right? USMLE step 1 by the end of your second year. Many emails they are received about it, that can we do it? Yes, you can do it. Beyond doubt, you can definitely do it. Pharmacology, pathology, they'll be holding quite a large volume of that exam. So it is good that if we start pharmacology at an early stage so that you start getting a better idea. Right? So this is the second reason. Third reason, as always, it makes the entire concept very interesting. So not only that we learn new concept, but it makes the subject very interesting, right? Because now we know that these are the areas where things can be implemented. And who knows that you might be visiting some hospital or you might be going watching someone's reports, and when you come across these medicines, so it will make a complete sense that yes, what you are learning is 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 such an important aspect of the entire medical science, right? Okay, so let's start. Again, this time what I've done is so many things I have already written, right? So that unnecessarily the time is not wasted and we can go for the say discussion part more. Okay? Huh. So wherever it is needed, I'll keep on adding extra. But as such, basic things are written. So let's start with the basic part. Right? This is basics. This would be our all-time strategy, starting with the basics. Just 5 minutes for that. So here is that in case of heart, we are dealing with myocytes, right? We are dealing with myocytes and we are dealing with pacers, right? That's what. And instead of heart, let's draw it like this. So we are dealing with myocytes and we are dealing with pacers. Pacers means those pacemakers, right? Pacers, I always like this word because they are like in marathon. They run, and if you follow them, you'll be able to complete the race within that stipulated time because they will be making or they will be adjusting for the speed, right? Same thing occurs over here. So here is the basic in myocytes. What really happens? Minus 96 millivolt. This is what RMP, resting membrane potential. And then through that gap junction, which is the specialty of cardiac cells, right? We'll be going this thing bit quick, right? And gradually, this is what is called as the phase 4. Gradually, calcium starts coming in, right, via that gap junction, and it reaches to minus 70. Minus 70 was what? It was threshold potential, correct? It was threshold potential, and at threshold potential, it fires, right? It fires because these are the voltage gated sodium channels, right? They start, sodium starts coming in and it starts rising, right? And this is the Dadagiri phase. When it goes up, depolarization. After depolarization, over top, over here, sodium channel stops, right? Now the potassium, the voltage gated potassium channels, they open. So potassium starts leaving outside. So this thing is called as what? Initial repolarization, right? Because now it goes down, right? But then voltage gated calcium channels, they kick in. Now they both balance, right? They both balance amount of calcium, amount of coming in and the amount of potassium leaving, they both balance, and that's why this is what is called as the plateau phase. This is a phase very important just for one important reason, because this is CICR, calcium induced calcium release, right? Small amount of calcium which is entering over here, it will be acting on reticular endothelial system, right? And reticular endothelial system is what? It is the calcium storage. So this calcium which has entered in, it triggers this RE, and this is the phase which will be the phase of contraction. Do remember this, because our drugs will be acting over here, right? Our drugs will be acting over here. Fine. At this point, calcium stops, calcium channel stops, potassium continues to go out, and it goes down, 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 down all the way. This is the final repol, right? Final repolarization phase, and then it comes to the baseline. Important part is this. Let me change color. Important part is this part. Oh, okay. Okay. So this is the refractory period, right? This is the refractory period. You know it very well. Refractory period. That is when even if other signal comes, it won't be creating any effect. But refractory period is of two types. The initial phase is what is called as the absolute. Whatever the level or the amount or the quantity of current you give, no effect, right? There won't be any effect. While the second part, what is called as the relative refractory period, correct? So over here, stronger impulse, right? Stronger impulse would trigger the reaction or the trigger the further process, right? So this is what really happens in case of myocytes. Myocytes will always follow, right? They will follow pacers, right? So basically SC node, AV node, they are the pacers. Whatever is coming out, right? Myocytes will simply follow them. So pacers are more important. True. This is what really happens in pacer. In case of pacer, three important things which are to be seen, which are different than myocytes. One, for pacers, they are like an electronic system. There is no physical movement. Myocytes, they contract. Pacers, they never contract, right? They just like electronic signal. They keep on sending the signals. So that's why few of the phases they will be missing from this. Let's start over here. Resting membrane potential, right? And this is the first thing, right? They are called as the funny channels. Funny channels, they are also called as the hyperpolarized activated C nucleotide gated channel, or the HCN channel. Hyperpolarized activated C nucleotide gated channels, right? So over here, there is definite small amount of sodium which is coming in. These are the funny channels. At one point, that is once again, it is our threshold potential, right? At threshold potential, the calcium channels, they kick in. These are the voltage gated. Now we can say that over here, two type, right? In case of heart, there are two types of channels, right? Say I'm sorry, heart chem. In case of calcium channels, right, there are two types of calcium channels, and these, let me light it here, right? In case of this calcium channels, right, there are two types of calcium channels, L type and T type. So you can say L type, right, they are used later. So over here, right, they are used later, and they'll be very fast, right? They'll be rapid. And T is to start, right? T channels, they are to start. So over here, depolarization starts. Initially, these T type channels, right? They calcium gate, right? These are the calcium channels, voltage gated. Calcium comes in, and then comes these L type, and it shoots right over here. So this is the depolarization phase. But over here, there is nothing like contraction, right? Because in pacers, they don't have to really contract. So then calcium stops. These potassium channels, voltage gated potassium channels, they start, and then it starts coming down. This is the repolarization phase, right? And things continue. Now, see, the thing is, it is this calcium. It is this calcium. This is very important because clinically speaking, right, whenever we talk about, so clinically, when we'll be discussing calcium channel blockers, right, there'll be one part which will be called as the calcium channel blockers. So whenever we find that these calcium channels are getting blocked, remember we are mostly dealing with, they are L type calcium channel blockers, right? So blockers means it's never like that was everything is completely and totally shut down. No, right? It's not like that. But it is like some of the channels they are blocked. Not all the channels are fully and completely blocked. Right? So that is a very basic thing. And what would happen? Just we are discussing. So if this calcium channel is blocked, right? If this one is blocked, not fully but partially. So for the example, let's say there are 1,000 channels, as such there are millions, but let's say there are 1,000 channels, and this our medicine has blocked, let's say 500 channels, right? 500 channels, so only 500 are available. So this is what would happen. Now this would be elongated, right? It will take more time for the calcium to reach to this peak in the further process, correct? Activity is reduced. Yeah, activity is reduced, so it will be taking more time to do the same activity, right, to reach to the same point. So this finally what would happen when things are, so it will slow down the things, right? So it will slow down the things. So this is just a basic, but why I'm telling this, that see, everything will revolve around these myocytes and pacers. Bus, everything will revolve around that. So you have to just understand that these pacers, they are like, they are shooting. Myocytes, they are following that firing, and how you are slowing down. And then there are SA node, then there is AV node, then we have got the pacers in the form of bundle of His, Purkinje fiber. So who is acting where, right? And over here we know this part, that this part would be atria, below will be the ventricles. AV is the only window available to send something, any electronic signal from SA node into the ventricles. AV node is the only one. Do remember this, right? We have previously also talked about it, but do remember this. Acha. Then in case of pharmacology, we'll be several times we'll be talking about this selective and non-selective. This word will come many a times, selective and non-selective, right? Just these 2-3 things you have to remember, and rest of the format will become very easy. Name itself tells that when we say selective, that means it will be acting only on certain areas. So it will be very specific. Make sense? Right? It would be very specific. Specific to what? It will come. Let's say beta blocker, right? So we know that there is beta 1, beta 2. When we say selective, it means it will be acting either on beta 1 or it will be acting on beta 2. But when we say non-selective, non-selective means it will be acting on all, right? So it will be acting on all. Now, when it is acting on all, chances of complications or the side effects will be more, because we want that it should be acting on only one receptor. It is acting on other receptor also, and other receptor is in other organ, right? So this is, just keep in mind, right? And you will see, yeah, broad spectrum. Well, broad spectrum, uh, we'll think it from the concept of when we'll be talking about antibiotics, right? Broad spectrum antibiotics. But well, in a very loose term, you can say that it is acting on all. Chalo. Another thing, arrhythmias. When we talk about arrhythmias, what is arrhythmia? Nothing very complicated. Simply speaking, abnormal path taken. The real path is SA node to AV node to bundle of His and Purkinje fibers. This is like normal path. But what if it is taking some new path, right? So that's where the complication occurs. New path can happen in two ways. One, SA node is our standard boss who is sending the signals for the entire life. What if someone else comes up that, okay, now I am the big boss? Now these nodes, right? These pacemakers, they have got one very bad habit. And that bad habit is, and actually I give the example of marathon, that when, let's say, you feel like on Sunday, this Sunday there is a marathon, right? So let's talk about a half marathon which is of 21 kilometers. And then there is a pacer, and this pacer, he'll keep on running at a constant pace, and let's say he is a pacer of 130. 130 means if you follow him, he'll be able to finish the whole race in 1 hour 30 minutes. 21 kilometers would be cleared. Fine, we have got this capacity and we follow this pacer, race finished. What would happen if someone from, say Kenya comes, someone from Ethiopia comes? Now they are like running machines, right? Let's say Elucid Kipchoge. Now he is a world record holder. He finishes half marathon under 1 hour, right? And he tells, okay, I am the pacer. Now he is the big boss now. He starts running, right? And he starts running at a mesmerizing pace. Now if we start following him, what happens? Definitely will collapse, right? Because he has got the capacity. We can't run at this high pace. He finishes in 54 minutes, 55 minutes. This is what really happens in this case. Our SA node is fine, is working at, let's say, 70 to 80 beats per minute, and the new pacemaker comes up and he is firing at 200. Now all our AV, bundle of hairs, Purkinje fibers, they have got the habit, whosoever is firing higher, follow them. Bus, that's where the trap comes, because then the entire heart goes into that high pace of activity and it fails, right? So this is abnormal automaticity. Now you know it very well that what is automaticity. Automaticity is without any motivation, they keep on firing the signals by themselves. Automaticity, right? There is no impulse needed, they fire it by themselves. But now there is some new unknown boss. That means there is some tissue who is firing at a higher pace, right? We'll see this thing in more detail, but this is one that leads to arrhythmia. The entire heart goes haywire. This is one. Second, so this is one. The second thing what it can do is abnormal re-entry. Abnormal re-entry is, let's draw here. Let's say this is a scar, right? This is a scar. Scar is what? Let's say when there is myocardial infarction, right? The tissue dies. When the tissue dies, in it is called as the scar. Now signals come. Signal comes, right? Signal comes and it will go round the scar and then comes back. Signal will go round the scar and it comes back. Now this is what is called as the re-entry. If there is no scar, the things will keep on going further and further. But there is scar, so it rotates, it winds around that scar and it comes back. This is re-entry. And re-entry is that is post MI. MI is myocardial infarction. By the way, tomorrow I am planning to take this MI. So today, if it is pharmac, so tomorrow it will be as good as we are taking the medicine, where we'll be combining everything whatsoever we have learned till this point of time. So there'll be anatomy, there'll be physiology, there'll be pharmacology, there'll be ECG, there'll be echocardio, there'll be angiography, there'll be management of myocardial infarctions, all the types of infarctions, I mean, starting with angina and all various types. So that's what we'll be doing tomorrow, right? Combining everything. So that's the scar, that's the re-entry. And then if there are some extra paths, naturally, if there is formation of some extra paths. Now see these extra paths, let me add one page. So this is SA node, this is AV node. We say that AV node is the only one, right? And it goes like this, right? Bundle of his and Purkinje fibers. But now there is one extra path, right? This is the abnormal path which is between so because this is atria and this is ventricles, correct? This is ventricles. This new path, somehow this path has formed. This is congenital, right? It is congenital. When this occurs, this is the abnormal path. So this abnormal path will be another entry, another one which will be sending signals from atria to ventricle apart from AV node, right? And when this thing happens, it can lead to so many complications. And this is one of the cause for what is called as the WPW syndrome. This is called as the Wolf Parkinson White syndrome, WPW syndrome, right? So just remember this is because of abnormal path, right? So over here, patient will be feeling, so all everything is fine when patient is living normal life, but as the heart rate increases and suddenly he'll start feeling palpitation, dizziness, right? And when you'll take the ECG, right, there is a very classical thing which you'll find in ECG of this WPW syndrome. Two things which are, one which is like say short PR, right? But that is not very say conclusive. But you will be watching what's called as the delta wave. Delta wave. Right? So the tomorrow I'll show you the ECGs of this WPW syndrome also. But it is so classical, I'll just draw it and you'll never forget it, right? So this is the P wave, and normally the QRS complex goes like this, right? This is normal. This is normal. In this case, there would be the delta wave. So why delta wave should occur? Because there is an extra channel and that is telling the ventricles, come on, contract, shuru ho jao, right? So this is the P wave and it goes like this and this. This is how it goes like. This is what is called as the delta wave, right? Which is the characteristic of this WPW syndrome. And it makes sense because WPW syndrome is like abnormal path which has been created from atria to ventricle. So instead of AV, it is sending the signals before. So if it is sending the signal before, that's why the PR interval would be shortened, right? Because otherwise the QRS complex was getting formed when the AV was telling ke chalo fire, right? But now the abnormal path has come, so it is not slowing down. So that's why short PR, now it makes sense. Short PR and the new delta wave, because normal wave is coming via AV, but before that, right? Otherwise this would have been the normal wave. But before that, that abnormal path has fired the trigger or the contraction of ventricles, and this is what it leads to. That's why this is dangerous when the heart rate increases, right? So this is, and this abnormal path is called as bundle of Kent, right? This path, abnormal path from atria to ventricles, right? This is what is called as the bundle of Kent. Okay. So here is, now we are starting with the pharmac part. Now see, in pharmac, almost every time it would look like there would be bomb. Matlab straight away, they will explode it. Classification. Type 1, type 2, type 3, type 4, and start. And it becomes difficult to remember that which class is what type and what medicines, because there will be dozens of medicines. We have tried to simplify it in such a way that you just think it and you'll be able to recollect it. So let's say when we say type 1, type 2, type 3, type 4, right? Type 1, we say alpha is 1, beta is 2, CAT cat, right? 4 is what? 2 square is 4. Now see what all these things are. These are, instead of writing sodium Na, let's write N alpha, right? Because it will be affecting alpha receptors. And alpha is 1, A is 1. So this is type 1. Sodium blocker. Sodium blocker, right? This point onwards, whenever we'll say blocker, that means we'll just cross it. So it is the sodium blocker. So easily we can say that type 1 is what? Type 1 would be the sodium blocker. Makes sense. Type 2. Type 2 is what? Type 2 is beta blocker. Beta receptors, right? Beta receptors, these are the receptors. So beta receptors, so it is a beta blocker. Beta receptors, there are like beta 1, beta 2. We'll come to that, right? When we'll be talking about type 2. But basically beta receptors. 3. 3 I remember CAT, cat, right? So we make it like cat, right? So this is cat. This K is our potassium, right? This is our potassium. So this will be blocking potassium channel. Now, even if I'm speaking this, you must have started thinking in mind, okay, oh, sodium is blocked. Fine, sodium is blocked, and immediately you'll know, catch sodium channels are getting blocked. Yes, what it will do? Where was the sodium coming, right? Sodium was going, and it was leading to what changes? Potassium is blocked. Yes, potassium, if it is blocked, then it was the second phase, that is the repolarization. If this is blocked, then repolarization would be elongated. Correct? Right? Acha. So that is there. Regarding the fourth one, right? First, because we have to remember type 1, type 2, type 3, type 4. In entire pharmacology, in all the classifications, there is some trick to remember, which is pertaining to that particular region only. Right? So we just see this thing once or twice, you discuss it amongst yourself, and you'll always remember. Calcium. Calcium is what? Plus 2. Now, when we say plus 2, we write calcium like as if it is a square. Correct? It is a square. So this is 2 square, right? So it is 2 square, 2 square, so that is 4. And hint is given by this calcium ions. Otherwise, all other are sodium, potassium, they are all 1. So this is type 4. And finally, we'll be having miscellaneous. These are some specials. So they will come, right? That is, it would be much easier once we discuss all of them, right? So here it is, our type 1. Now see, to make things complex, what has been done is the type 1 is further subdivided, right? We just add page. It is further subdivided. So this is type 1. Type 1 is divided into 3 types. Right? And when we say that they are divided, so it is not only that they will be divided with the perspective of say the medicine, even their action, their duration, everything changes, their power. So we say type 1A, type 1B, type 1C. Out of that, the C is most powerful, so that's why we'll be writing it like this, right? Then the next one, right, the next most powerful is type A, so we'll be writing it like this, and the least powerful is B. So this is their strength, right? This is their strength. There would be separate medicines, and we'll talk about it. Achha. Right? So this was anti-arrhythmia, and in this we talked about this type 1, type 2, so right, type 1, type 2, type 3, and type 4, right? These are all types. So type 2, type 3, type 4. Okay. And finally the miscellaneous. In type 1, now we are watching for this. So in type 1, we have got ABC, and the strength is like this. Now here. In type 1, which is middle, which has got the double arrow, right? Double arrow. Double arrow is this C is most powerful, A is the number 2. But we'll remember it like as that it affects sodium, it affects potassium, both of them. So this is easy to remember that when we discuss, right? B is least powerful. This is the number 2. Number 2 means 2 ions. So it will be affecting sodium and potassium, right? When the sodium and potassium, they are affected, right? we are coming across one new concept, and that is state dependent. State dependent. Whenever you come across this state dependent thing, that means when we say it is selective and when we say it is effective. Selective means it is if on selective on effective side, so it will be making its effect wherever the need is. Effective means that it will be effective even in severe cases. There you'll find that some of the medicines, they are not effective in severe cases, right? Some of them they are, yes. So these are the two important criteria, the whether things are selective or effective. If they are like effective but it is not selective, that means it will be affecting even at other sites also. When it is affecting at other sites, it will be causing complications, because we want to correct one thing and it is going at four different places and leading to complications or the side effect of drugs. That's what we'll see, right? Effective means efficacy. Means if you give some dose, you should be getting the response. It should not happen that efficiency is so low, though it is selective, but efficiency is so low that you have to give such high dose that won't be feasible for the patient, right? So here it is. When the sodium, think of we are talking about myocytes, right? Just the look at the graph itself will say we are talking about myocytes. So here, when the sodium is blocked, yes, we know that these are the, when these sodium channels are blocked, right? These voltage gated sodium channels are blocked. Out of 1000, let's say 500 are blocked. Yes, you only use some good word. What was? Activity is reduced, right? Activity is reduced, so it will be taking more time. So the graph would be prolonged, right? Graph would be prolonged. Correct. Graph would be prolonged. So that is the sodium channel when the sodium is blocked. But this class 1, we said that it is 1 is this class 1A, right? This class 1A. It is affecting both sodium and potassium. So this is what really happens. It will be prolonging. It will be affecting even this 1, 2, 3, right? The the plateau phase also, that would be affected. What will be the final result? The final result will be, there will be the increased, that is prolonged, right? It would be prolonged QRS complex and it would be prolonged QT segment. The final thing is there would be slower heart rate. Heart rate would be slowed down, right? The target would be 1, 2, 3 atria, ventricle, Purkinje fibers, right? So when they are affected, atria are affected, myocytes, ventricles are affected, right? So they will be leading to slowing of the heart rate. So that is what would be done in case. So caution, class 1, right? It should not be given to heart failure patients. Heart failure, when the heart itself is failing, right? This is what is called as the weak heart. If you give this thing on a weak heart, heart is already weak, you are slowing it down further, it will lead to hypotension, decreased blood pressure. Because blood pressure is what, when the ventricles they contract, right? And they throw the blood. When they throw the blood, and it is the pressure which is exerted on the walls of those arteries, that is the systolic blood pressure, right? And when heart is relaxing, at that point, how much is the pressure? It is the diastolic pressure. So diastolic pressure is the minimal load which always your body is taking, and systole is the highest pressure which is exerted when the heart is contracting, right? So when the heart itself is feeling and you slow it down further, so that heart would pump slow, that it will lead to hypotension, right? Now let's come to this drugs. This is type 1A, right? As we said, this is up, right? Now, say this is quinidine, right? This is the first medicine now, quinidine. It leads to, the side effect is synchronism, right? Now, when such questions are asked that what is the side effect, it becomes very difficult to remember it. Anyway, let's watch it. Tinnitus. What is tinnitus? As if in ear some, right, the sound is coming, right? Those sharp tingling sound in the ear. So let's draw ears. These are the ears. Something is happening in ears. Blurred vision, right? So these are the eyes. right? The blurred vision. And what is happening? Headache. So this is a headache, right? Remember it. Something like this. So this is the area which is affected, right? This is the area which is affected. So this is like a crown, right? And crown is worn by the queen. So when it is said queen, the queen means this much head, right? Because the crown is over here. So that is the quinidine. And it leads to blurring of eyes, tinnitus, and the headache. Combined together, it is called as the synchronism. But even if you say this much, that tinnitus, blurred vision, headache, right, that is more than enough. So now this is easy, right? We can remember this quinidine easily from the queen, from the queen. So that's good. Next one, right? We'll say as such this procanamide comes, but we'll see this diisopyramide first. Why diisopyramide? Say it has got, it leads to hypotension, it leads to eyes, mouth, that the eyes, watering of the eye, mouth becomes dry, right? Anticholinergic, urinary retention, all these things are happening. So how to remember it, right? When we say diisopyramide, so this is like pyramid, pyramid. Pyramid is in Egypt, right? Egypt. So all desert. So over there, right? All these things, eyes, mouth, right? That becomes dry, urinary retention because there is no facility, blood pressure decreases, right? Collectively, what you are learning is anticholinergic effect, right? This is anticholinergic effect. So this is diisopyramide. Regarding this procanamide, right? Professional one, procanamide. So this leads to, this is like WPW and systemic lupus erythematosus. But say for for time being, just put a star, right? Procanamide. Right? We are not worrying much, just we are remembering a name over there. One another word. When we say inotropic, this is the word which will keep on coming in heart. Inotropic. Right? Inotropic means with what power the heart contracts. It is the indication of strength. So inotropic effect is there is increased strength. When it is said negative inotropic effect, that means decreased strength. So previously heart was contracting like this, now it is contracting like this. Its strength is decreased. So the use of these medicine, right? 1A is used in supraventricular tachycardia, right? If we are not remembering much, but even if we remember that it is tachycardia, whether it is ventricular tachycardia or supraventricular tachycardia. This SV is supraventricular, this is ventricular. But there is tachycardia, and we want that we want to slow down the heart. Done, right? We now know it very well because it will extend the entire process. It will lead to activity would be reduced, reduction in the activity, right? So that's why when it is slowing down, so there will be decreased strength, there would be hypotension, right? But it is called as negative inotropic effect, right? Let's move to class B. Now this class 1B, right? This class 1B is doing only one thing, sodium blocker, right? Sodium blocker. And when it is sodium blocker, at the same time, there is one more thing. Now this is, it makes sense because it is affecting only sodium. Not only that, even from the perspective of entire heart, it is affecting ventricles and Purkinje fibers. It is not affecting atria. It is not affecting atria. This is the reason, right? Its effectiveness, from the effectiveness, if we see that yes, A was more effective than B because A was acting on everyone, and say this B is acting only on ventricle and Purkinje fibers, not on atria. So this is one more reason. What are the important things in this? This act on depolarized cells. Now, what's the big deal? Otherwise, if we really feel like we read this, that class 1B drugs, they act on depolarized cells. So what? Right? Because over here, right, as it goes, so it is this these cells, right, that in the depolarization phase, right, it is in the depolarization phase, that's where it will be affecting, right, it will be acting on depolarized cells, or let's make it still more, still better, acts on, if we say depolarization phase, right, this would be still better, depolarization phase. Yeah, because that's where the sodium is coming into picture. But let's go slightly back. Let's go slightly back. Right? Over here, right? Over here, this is sodium, right? That funny channels. But otherwise, the game is of this calcium and potassium. But over here, this is where the sodium role is. So we can say that it will be affecting more on myocytes, because this is what was happening on myocytes, right? Because this is the phase which is important from the perspective of sodium, right? Because after that it is taken over by calcium and potassium. Okay. So this is one, and this is very much beneficial. Ischemia affected myocytes. Ischemia affected myocytes. Right. So this is something which is very interesting. So tomorrow when we'll be talking very much about these class 1B, that they are not that faltu, right? They are important. They are used in the treatment of ischemic arrhythmias. And these arrhythmias are very common post heart attack. Right? Once the heart attack comes, that particular night, let's say someone has got the heart attack in the evening part, that night becomes very crucial, because chances of ventricular tachycardia, they are very high. Invariably it occurs, invariably, so you have to be on alert. So that's why this ischemic arrhythmias, because see, as the scar develops, tomorrow you will know that the scar has got a life cycle. So as the scar develops, heart though is constantly beating, constantly the pulse is going from SA node to AV node, and it is constantly coming till the scar is not developed, right? Things are okay, but as the scar develops, there would be re-entry, and that will lead to development of those arrhythmias, right? So that's why the timing is so important, and this is one important thing which you do remember. Tomorrow you will be very happy with yourself about this part, right? Ischemic arrhythmias post MI, right? Typically post MI, myocardial infarction. Right? By the way, one very, very interesting mail, right? I don't know, some time back I must have used the word infarction, and you corrected me in mail that it is infection. No, gentlemen, infection, and this is what we are talking about, is infarction. Farction. Infarction is the lack of blood. Infection is obviously the infection, right? Bacterial or viral or whatever. So this is, we are talking about in heart, we are talking about infarction, right? Huh. And in that mail only you said that can heart have infection? Yes, heart can have infection, right? It can, because infection can spread anywhere. Achha. So this is ischemic arrhythmia. Now this is the medicine maxillating. Its adverse effects are classical GIT syndrome, right? GIT symptoms. So when we say GIT, then remember it like this. This is a symbol of McDonald's, right? McDonald's. So you eat McDonald's and then there would be GIT upset, right? there would be GIT upset. So N is nausea, V is vomiting, and D is diarrhea. So from now onwards, whenever we'll write signs symptoms of GIT, we'll always be writing N/V or /D. So that we don't have to write again and again, right? So it becomes easy. And this lidocaine is one of the very powerful local anesthetic. So when it is local anesthetic, this lidocaine can have CNS toxicity, because then and then it is anesthetic, right? It slows down our entire consciousness. So this is like CNS toxicity if given in more quantity. And this digoxin is nothing but our special drug, right? Type 1, type 2, type 3, type 4, and then there was special. So this is the digoxin, which is into falling into our special category, right? We'll talk about it at the end. So this is type 1B. The keyword which you'll take at home, it won't be affecting atria. Yeah, xylocaine, procaine, all same, bhai ban, right? So atrial, it won't be affecting atria. It is acting on only sodium channels, and very important that it is used in ischemic arrhythmias, right? On to the class 1C, the most powerful, most effective, right? And they are, yes, acting on all atria, ventricle, Purkinje, then and then they can be so powerful, right? These are flecainide and propafenone. They're classical because they are so wide acting on sodium, but their action is very powerful. Because of that power, it can cause arrhythmias because the drug is very effective, very powerful. General and local anesthesia. Well, general anesthesia is like when the entire body, right, is anesthetized. In other way, person is person loses his consciousness, right? He goes to good sleep. Local anesthesia is only that particular portion is anesthetized, right? Say for example, cataract surgery. Right? So in cataract surgery, it is not the general anesthesia is given, that entire body goes into the anesthesia, he goes to sleep. No, only that local. So patient is conscious, right? Patient is knowing something is happening, right? Regarding digitalis, yes, it is a special drug. It will come at the end, so we'll talk about it, right? Because it is out of that type 1, type 2, type 3, type 4, and the specials. So it comes into that. And so I was talking about cataract surgery. So over there, right? So it is used. Say for example, tooth extraction. So the local anesthesia is given and then the tooth is extracted. But sometimes it happens like the tooth is so deeply embedded, and in spite of giving anesthesia, because you can't keep on giving more and more local, when the limit is reached and then it is felt like it, now even if we are pulling that tooth out, patient is shouting, and in order so that other patient should not run away, that's where you can give general anesthesia so that that tooth can be safely extracted. But yeah, general anesthesia has got its own complications, so that's why it is not preferred much, subject to when it is really very much needed. Okay, so here it is type 1C, and in type 1C we talked about, say, that it has got wide action, right? That's the reason, because it is so powerful. See, it makes complete sense. Ventricular tachycardia, that means that night post MI. So that is fine, but one more important thing, refractory arrhythmias. You have given other medicines and it is not giving the effect. So you need a power. So because of the power, because in refractory arrhythmias, you know that it is only the stronger impulse it can take control of this arrhythmia. So that is where type 1C is used in the form of propafenone or flecainide, right? So just remember, type 1C is for the power. Moving on to the type 2. Okay, before we go for type 2, a small page of description, discussions, concepts. ANS, right, autonomic nervous system, in which we have got the parasympathetic and sympathetic, right? And in ANS, ANNS, we are dealing with the cardiovascular system, right? We are focusing only on this. So we have got the adrenergic receptors. Only we are restricting only to this much. Otherwise, so there are so many, but we are restricting to only this much. Beta 1, beta 2. Beta 1 is present in heart, right? Beta 1 is present in heart. Beta 2, they are present in smooth muscles in blood vessels, right? Okay. So in heart, we have got the pacers, we have got the myocytes, we know about it. And in pacers, what it does, it opens L-type calcium channels, right? So this is phase 4, right? That's what is over here. And in myocytes, it is the phase 2. Phase 2 is over here because we are talking about beta 1 receptors, right, which are present into heart. So here it is. Class 2 beta, it prevents binding of norepinephrine or epinephrine, right? Yeah, it will come, right? So beta 2 is to, because smooth muscles in blood vessels and lungs, right? So deliberately I have not written it over here, so we'll add it, but you have said to, yes, that's why this space was left out, this space, right? Anyway, we'll come back to that. So class 2, class 2, right, it is the beta, prevents binding of norepinephrine. So this is when it is selective. When we say selective, that means it will be affecting beta 1, right? Now all these beta blockers, right, these are the beta blockers, right, beta blockers. They end up with olol, etinolol, S-butylol, beta-xolol, S-molol, metoprolol, right? When we say non-selective, that means it is beta 1, beta 2. So like timolol or propranolol, so they will be acting on both of them. Will it make any difference, right? When it is acting only on beta 1 and it is acting on beta 1 and beta 2, both will be making any difference? Well, let's see. So it acts by calcium which is entering the cell, phase 4 in pacers. So result, calcium which is entering into cells, the moment that is blocked, yes, it will be leading to slowing of the heart rate. Now the mechanism is different, right? Previously the sodium was getting affected. Now we are affecting the calcium. So all channels are working fine, but when the calcium entering is less, so obviously heart won't be having that much calcium which can come out from reticuloendothelial system, and it will lead to decreased heart rate and decreased conduction velocity at AV node, right? See, now the things are coming up. It is affecting even the AV node conduction. So this is what really happens in class 2, because it is affecting the receptors, right? It is not only the sodium channels which are affected. So here long PR interval makes sense because things are elongated. In myocytes, contraction phase, yes, that's what it, so there would be weak contraction of heart because less calcium, right? So oxygen requirement of heart decreases, right? Oxygen heart rate, it decreases, so that is good, right? This is why you'll be giving it in supraventricular tachycardia, that is atrial fibrillation flutter, when the heart is going at such a high pace. Yeah, action would be, the final action would be same. The only thing is how it acts, right? So that's what saying, they type 2, they are not affecting the sodium channels, right? And they are affecting calcium. So, and this is post MI prophylaxis, post myocardial infarction prophylaxis. So this is how it is used. Regarding the adverse effect, cardiac and non-cardiac, right? These effects, that is cardiac and non-cardiac, why is it so, right? That they both are. The reason is that this is the SA node, decrease in the SA node, so there would be decreased heart rate. Bradycardia can lead to heart block or heart failure, right? If they are affecting in excess of stimulation. Regarding the non-cardiac, fatigue, sedation, sleep disturbance, sexual dysfunction, dyspnea, bronchospasm, right? In non-selective. Why the bronchospasm? Because something which is so important. The reason behind it is that we talked about beta 1 and beta 2 receptors, right? And we said that when things are non-selective, it means it will be affecting on beta 1 and beta 2 both. When it is acting on beta 1 blocking, beta 2 blocking, so that is these beta 2 receptors which are present in lungs. This is the reason that for non-selective, you your patient gets bronchospasm also. One another interesting thing, hypoglycemia, unawareness, right? Hypoglycemia, unawareness is what? Normally, when there is hypoglycemia, there is tachycardia, there is palpitation, there is tremor. But when these things are not felt, means glucose level is dropping, but these things are not felt, that is what is called as the hypoglycemia unawareness. Right? So when we give, so this is a word of caution. Class 2, that is all those beta blockers, right? Beta blockers should not be combined with calcium blockers. Because see, when we are blocking, right, when the beta blockers are blocked and even the calcium is also blocked, so obviously it will lead to such a severe block because there will be decreased conduction velocity of, say, our atrioventricular, that is our pacers, that it can lead to AV block. Now this would be a complication, right? Atrioventricular block, right? From atria to ventricle, the complete block. And this thing can prove very dangerous. So that's why, because it is like you have sent, right? कुछ झगड़ा हुआ, instead of one person, you have sent the whole team. So obviously they will be shattering that person. Same thing happens, right? These are the two powerful drugs, they are acting, and that leads to block. Contraindication should not be given in this pheochromocytoma and cocaine toxicity. Right now, we think it like that, that they lead to vasoconstriction. Right? Now, what vasoconstriction? Say this is one tube. The amount of fluid in this tube is fixed. Right? When you do, and when this tube is constricted, right, volume remains the same. So now there is less space. So less space, that means there would be more pressure which would be generated on the walls, right? So that is, there is, it will lead to increased blood pressure, and that increased blood pressure may lead to a rupture or the damage to the, say, aorta, and that is what is called as the aortic dissection. The inner wall, right, inner wall is damaged, and that leads to aortic dissection, a fatal condition. So that's why it should not be given. On to the class 3. Class 3, we remember it like cat, right? 1, 2, 3. So this is, say, acting on potassium, right? Now, this is amiodarone. It is acting on sodium, then beta blocker. This was beta blocker. This fourth one was calcium, and this one is the potassium, right? So everyone, class type A, type 2, type 4, and this one is type 3. Everyone has got a separate action, right? Ventricular tachycardia, atrial fibrillation, atrial flutter, yes, it can, because when it is acting on potassium, right? Remember, it is acting on potassium. So that entire process of repolarization is slowed down, right? It would be affecting the repolarization. Yeah, here I have written it. Phase 3, repolarization of myocytes. So there will be slow calcium intake. So there is a slower repolarization. Slower repolarization means the prolonged effective refractory period. So everything would be slowed down. That leads to decreased heart rate, and decreased heart rate, that means there would be longer QT, because QT would be extended, right? The whole thing is slowed down. The trouble is, this drug is not used much because it has got a long half-life. Now, this is another word which you'll be learning in general pharmacology. That is, as soon as you give drug, it reaches to its peak level. And then within how much time its efficiency is reduced by 50%. So that is what is called as the half-life. In this case, half-life is 20 to 100 days. So it is a super long effective drug, right? It keeps on acting for very long duration. When it happens, so the chances of toxicity becomes very high, right? Because this drug is so much of lipophilic, right? So this is lipophilic, lipophilic, fat loving, right? So it gets bind and it keeps on acting. That's the reason it is used less, because it has got chances of very high toxicity in the form of pulmonary fibrosis, liver dysfunction, heart blocks, so many complications. The next, this is the drug. Once again, this is like type 3, right? So one is this amiodarone, very long acting, and this is drondaron, right? Drondaron. It works quite similar to amiodarone, but the best is it has got the shorter half-life. When it is shorter half-life, then that half-life is of 24 hours. Now it makes sense. So we can control it in much better way, used in atrial fibrillation, atrial flutter, right? Fibrillation, flutter when the heart rate goes about 200, 230, right? So it is necessary to slow it down. Side effects, you know this: GI, nausea, vomiting, diarrhea, right? Can you repeat from start? I'm lost. Means from where? From where? We are talking about this amiodarone, right? In amiodarone, it is long half-life of 20 to 100 days, so it is pretty long, right? Pretty long. So that's why its toxicity is pretty high, right? Toxicity is pretty high. And over here, right, this drondaron, that is where its half-life is good. It is 24 hours, so it is much easier to control it, right? Much easier to control. That is used in atrial fibrillation, flutter, same as like amiodarone. Side effects would be GI, right? Nausea, vomiting, and diarrhea. So this is what we are talking about, class 3, in which the potassium is involved. When the potassium is involved, obviously potassium it comes into picture into the repolarization phase, right? So here, this is the phase which would be affected. This is the phase which would be affected, right? And it would be prolonged. When it is prolonged, so over here, right? So this is like Q, R, then the sync is S, and then the T. So this QT interval on ECG, this QT interval, that would be prolonged. Makes sense, because only the potassium is getting affected. So potassium will lead to long repolarization wave, so longer QT wave. Sorry, longer QT wave. And then comes sotalol. Sotalol, right, is a non-selective beta blocker, right? Remember, it is non-selective. So ventricular tachycardia, atrial fibrillation, flutter, everywhere it would be affecting. And side effects would be bradycardia and the hypotension, right? Hypotension, because it is affecting not only beta 1, it is affecting beta 2 also. Beta 2 means it is affecting on lungs, if it is affecting on blood vessels, and that is leading to the hypotension. Another one, these are the drugs ibutilide and dofetilide. I is for intravenous, dofetilide is oral, but this is for acute and this is for long term for atrial fibrillation, right? Some of the drug names I have mentioned, don't worry about it if you can't remember all of them, no worries at all. Just idea is to know the whole concept in general. Okay, all these drugs, right? This class 3, right? This type 3, which is a beta blocker, so powerful, and that's the reason that side effect can be torsa de pointis. Torsa de pointis is a sort of ventricular tachycardia, right? Sort of ventricular tachycardia, but in this, the important is there would be irregular QRS complex, right? So that's why it is called as the classical word, right? It is the key word. It is called as the polymorphic ventricular tachycardia, right? Polymorphic ventricular tachycardia. And this happens in those patient with long QT interval. Now it makes sense, because when we are giving this drug, QT interval is getting prolonged, right? QT interval is getting prolonged, and that's would lead to rapid, irregular, right? Rapid, irregular QRS complex. Right? Now, this torsa, the point is, this is seen pretty common, and you have to actually take extreme care whenever you encounter any of the kidney damage, right? This is what we'll be talking about in length when we'll be talking about the renal system. But do remember, whether the damage is acute or chronic, few of the important medicine which you should not be giving aankh band karke. No, right? Whenever there is acute or chronic kidney damage, you have to adjust the dose, right? Adjust the dose of, if not more, because this is a huge list, but at least these basic medicines, so you should know. One is very common, Ciplox or ciprofloxacin antibiotic, right? Adjust the dose. Well, because they can lead to torsa, the point is, if the kidney is damaged. Just remembering this much should be more than enough. Then sotalol, right? We just talk about it, sotalol. Procanamide, right? Procanamide. So if there is, and how will you see whether the kidney is damaged or not? In anyone's report, if you see that GFR, glomerular filtration rate, right? You just watch it, right? And if it is going low, right, below 0.65, so then you know that this is the kidney damage. Watch for creatinine, right? Watch for if there are presence of any pus cell. Watch for whether there is presence of glucose in the blood, in the urine, right? So that's where it is. How many drugs do we have to remember? Well, no one would ask you all those chota drugs. No, no one, right? But gross drugs, bigger drugs, right? That you have to remember. And still, most important, the concepts. You should remember the concepts regarding, and then as we'll proceed, as we'll actually be learning, when we'll be learning the pharmacology, you'll find that automatically things will start coming in your mind. Yeah, this only because it is ending with olol, so that means it is this. Right? But yes, initially, I would say, even if you don't remember more drugs, no problem, concepts, right? Then let's say this is fluconazole. Fluconazole. These are some very important. There is a big list, but this much is sufficient. When the kidney is damaged, take care, because they can lead to, those are the pointers. Now we move on to the calcium channels, right? Now in calcium channel, because our type 4 is what? Calcium channel blocker, right? See, in our body, everything is interconnected. So when we say calcium channel blocker, to calcium channel, they occur at so many other places, right? Over here, we are dealing with calcium channel blockers, and that also restricting ourselves to non-hydropyridines. Non-hydropyridines. So it means there are two types of calcium channels. One which is the dihydropyridines. Now these dihydropyridines, they act on smooth muscles of vessels, right? So same principle, same principle. The commonest drug, amlodipine or nifedipine, you must have heard people talking about these medicines, right? Usually they are taken, right? Nicardipine, nifedipine, all these very common medicines for hypertension. And what they do? Same, we just talked about it. That here is the high blood pressure, right? The volume is this much, right? The pressure on the wall is high. If it is acting on smooth blood vessels of vasodilation, simple vasodilation. When the vessels are dilated, so now there is more space, right? More space. So obviously the pressure on the wall, previously it was so high, right? Now it is relatively reduced, because fluid to will remain as it is. Now, yes, I agree. In vasodilation, in treatment of hypertension, you give Lasix, right? So Lasix will do what? It will decrease the fluid load, right? Because so that is how you have got various actions about how to handle the hypertension. That's right, right? But you do vasodilation, yeah, same. Now the fluid is that much only, but the vessels are dilated. So now the pressure on one particular segment of the vessel that is decreased. Right? But we are now dealing with the non-hydropyridines because that is the class 4 antiarrhythmics. These are the class 4, right? In class 4, the commonest and the most important which you can't afford to miss is the verapamil. I remember the verapamil like this. I remember the verapamil like this when I write verapamil like this, like this. This is 4, right? This is 4. So this is type 4, right? Because we write 4 like this. ठीक है ना? We write 4 like this. So that is verapamil. Verapamil is what it's doing? Calcium channel blocker. Calcium channel blocker. So it means it will be taking care of the calcium part, calcium which is entering the cells, right? That is something which is leading to CICR, right? Calcium induced calcium release from the endoplasmic reticulum, right? So pacers, phase 4, phase 0, right? Decreasing calcium entry cells. So there will be prolonged effective refractory period. So heart rate is slowed down, right? Calciums are affected. Also conduction velocity on AV node, that is also decreased because you are restricting the calcium, right? You are restricting the calcium. So that calcium which was utilized in both the cases. And in on myocytes, so yes, it will straight away affect that plateau, right? This plateau, because this is the plateau which is for the contraction. So when this is prolonged, obviously it will lead to weak contraction, right? Weak contraction. So verapamil is selective for cardiac calcium channels. Now tomorrow we'll be starting with angina pectoris, right? Angina pectoris, that is the initial stage. It is not a full-fledged developed heart attack, right? But it is the beginning. Then the supraventricular tachycardia in the form of atrial fibrillation, atrial flutter, all these things will be discussed. But the thing is that in such cases, cardiac calcium channels, right? Calcium blockers like verapamil that is used. Diltiazem, this is also cardiac and vascular calcium channels, hypertension and SVT. But do not use with beta blocker, right? We wrote this thing even before also when we were talking about beta blockers, that please don't mix beta blocker plus calcium channel blockers, right? It should not be done because then it can lead to, say, heart block, right? Constipation, flushing, because the combined effect of all, but heart block and death, right? On to the miscellaneous. This is adenosine, and its action is very short, just 10 seconds, right? Super fast, just 10 seconds of action. Onset is within 20 seconds. So this adenosine, which is given intravenously, right, on the subtype A on the pacers. So calcium channels, they open, calcium starts entering in, and over here L-type calcium channels, they are blocked, so there is decreased conduction, and that's the reason it is used in supraventricular tachycardia or WPW syndrome, Wolff-Parkinson-White syndrome, when there is need to decrease the conduction speed, right? You want to decrease the conduction speed or decrease the conduction rate. That is what is needed. So that's where it is used. Here is the digoxin. Same principle, right? Same principle. It decreases heart rate, decreases conduction velocity, short acting. Side effects, arrhythmias, atrial tachycardia, AV block. Because see, if given in overdose, right? In cases of overdose. So that will lead to its side effect. Other are magnesium sulfate, magnesium chloride, but say they are very powerful in treating severe arrhythmias and digoxin toxicity, right? Yes, yes, they are same, right? So this is about a very, say, a complete outline, but with the important concepts of the cardiac pharmacology. Now, what we do is in just one page, right? In just let's do the summary of everything, right? So, even if you remember that much summary, that should be more than enough, right? So, here is one. We remember the one like what? Sodium. But we write sodium like this, alpha, and it is the sodium blocker. In that we were having A, B, and C. Who was most powerful? Well, this was most powerful, right? Who was the second? This was the second. Who was the third? This was the third, right? In the power. When we talk about A, we remember the queen, right? That is quinidine. Quinidine. So it was the queen. So we just draw this, right? Blurred vision. Over here, in here, it was tinnitus and the headache. So that's the crown. That's the crown. So that was our quinidine, right? Then the second was diisopyridine, right? So it was diisopyridine. Pyridine, that reminds us of, say, pyramid. Pyramid, so in this pyramid, when things are not available, right, it will lead to all those things collectively called as the anticholinergic effects. And in anticholinergic effect, right, it was dry mouth, right, dry mouth, eyes affected, urinary retention, right? So anticholinergic effect. And obviously there was one more procanamide, but right now we are not writing it. It's okay, even if you remember this much. In B, right, in B it was, we are changing the color. It was that local anesthetic, lidocaine, right, lidocaine. So that was local anesthetic. And then there was McDonald, right? It was a McDonald, right? Maxitine. And Maxitine, this is the Maxitine, which gives complications, GIT, GIT symptoms. So nausea, vomiting, diarrhea, the commonest one, right? Then comes our third one. Third one, that is type C, the most powerful. All those atenolol, acetabutalol, esmolol, right? All lol. Atenolol, esmolol, right? Etc. All lol. So that is was the type C, right? Wait. I mistake. That was next, right? The C was what? C was that typical name, right? That flecainide, right? That was the thing. Flecainide, right? Just rewind. Because all also they are beta blockers. So where are we? Here it is. See, flecainide, right? Flecainide and propafenone. Now it is okay. Right? So flecainide and propafenone. Propafenone. So this is one. Now we move on to the second one. Two, that was beta. Beta is beta blocker. In beta blocker, we made that selective and non-selective. Right? Now it makes sense. Selective and non-selective. And in selective, it was all those, right? Atenolol, then esmolol, right? And acetabulol, propranolol, right? propranolol. In non-selective, it was very typical, right? Which was tenolol, right? So tenolol. When we say non-selective, that means this is affecting on all. Tenolol, that is tenolol or timolol, right? Timolol. Timolol is like a team. Team means everyone, right? Team means everyone is involved, right? When everyone is involved, so that's why it is non-selective. So that is timolol. Right? By the way, propranolol was selective or non-selective? My guess is propranolol was in non-selective because say timolol, and this is a professional team, right? This is a professional team. So when we say professional, so they are pro. So propranolol, they are professional, so they affect everyone, right? So it must be non-selective. It must be non-selective. Just a minute. Just a minute. Let's check it out. Uh, Class 2. Propranolol, right? They are professionals, right? And this is a team. So this is like a professional team. And when we say team, that means it will be affecting everyone. So that's why they are non-selective, affecting beta 1 and beta 2. So they will be affecting lungs also. That means both those medicines, they can lead to bronchospasm, right? So they can lead to bronchospasm. So this is 2. Then comes our 3. 3 is K, potassium blocker, right? So over there, we remember that all the drones, they were there, right? Amiodarone, right? Then drondaron, right? All those daron, all those Terminator sort of names, right? And then the sotalol. So these are the type 3. Then in type 4, we have got the calcium channel 2 square, right? And in that there were 2 types, right? Dihydropyridines, and they are these dihydropyridines, they are for treatment of blood pressure, right? Treatment of blood pressure. And in treatment of blood pressure, the commonest name you will ask most of the time, amlodipine, right? Amlodipine, nifedipine, right? Nifedipine, they are used. What will they do? They are affecting blood vessels. So blood vessels would be dilated. Vasodilation, blood pressure comes down because fluid remains that much only. We are not giving Lasix or furosemide so that the fluid is pushed out of the body and the blood pressure comes down. Both the ways it can be done, but this is what we'll be doing it over here, right? And in the calcium channel blockers, what we are non dihydropyridines, right? This is for the heart. So non dihydropyridines, and this is verapamil. Very right, because 4, right? 4. So verapamil. Verapamil. Never forget verapamil. Second is that diltiazem. Diltiazem. Right? So these are the medicines for that. And finally, we have got the special ones. Right? These are the specials. In that special, digoxin. Right? Very powerful. Right? Digoxin. And then we have got the magnesium sulfate, right, which are used for this ventricular tachycardia, and magnesium which were magnesium sulfate, and what was magnesium chloride, right? Magnesium chloride. And there was one which was to be given adenosine, right? IV adenosine. So these are the special ones. This, these pages, this is like a summary, right? This is like a summary. For pharmacology, always do it like this, right? First understand it, then try to write down the summary. Revise the summary, and for that revision, I always prefer, these are your sleeping hours. This is your time when you go to sleep. Just before sleep, go through this summary. As you wake up, go through this summary. You just do it for 3 days, right? 3 days, 72 hours. Always called as the magical phase for human body. You revise it over here and over here, here and here, and see what happens. Right now, you'll be learning pharmacology without any pressure. Aram se you are learning it. At the same time, it is improving your physiology concepts. And tomorrow, when we'll be dealing with myocardial infarction, heart attack, right? That is the topic for tomorrow, myocardial infarction. So in that case, we'll be taking even the histology part, even the pathology part. What my wish is that I prepare you for USMLE part 1. Right, part 1. There is no need to wait. One question which was asked, that is it necessary to wait for all the 5 years and then appear for it? No, not at all. Not at all. If you meticulously work for first year, second year, by the end of second year, right, you will be ready for part 1. Right? The trouble occurs when lots of time is wasted, right? 6 months they are wasted without any significant work. And then if you try to squeeze the entire thing, then it is problem. And then also, if say, without understanding, if we just keep on doing that ratification, to gaye kaam se, then it is impossible. Right? Because suddenly at the end there would be so much of load that all those rata, all those cramming work, right? That is like a suicidal thing. So that's why tomorrow when we'll be dealing with myocardial infarction, so there'll be lots of medicine in it, right? Lots of medicine, but it would make a complete sense because everything will be based on the physiology and anatomy and whatever the pharmacology is needed, that we have discussed today, right? So that's why tomorrow you'll find things really very comfortable. Okay, so we stop at this point. I just, let me save this thing. Okay, saved. I'll put it into our folder, right? So thanks a lot. Thank you so much. Right, and we meet tomorrow at the same time. Okay, thank you and bye bye.